Hey Re.Fam, my name's Kate and welcome back to Keeping It Real, the go-to podcast for stats. If you're a bit surprised by this topic, you've obviously never met Dr. Richard Bloom, a man almost entirely fueled by data sets. Today we chat about why the surgeons audit each other's work, what started it in the first place, and how ultimately it leads to better patient results. What does it mean to audit work in the plastic surgery world?
Well, you're very lucky, Kate, because you've got Mr. Plastic Surgery Audit sitting in on this podcast. So I've always been interested in audit, going back to in the hospitals, even before I started doing plastic surgery. Plastic surgery is, I think, the hardest specialty to actually audit, because for us, the main thing is the long run outcomes, not the short run outcomes so much. Whereas most other procedures, if it's appendectomies or a bowel resection, most of their sort of key performance indicators are in the first 2 weeks, whereas ours are really more long run outcomes. So I've done audits all through my training, and then we set them up when we started at Epworth. We used to do them with like all the plastic surgeons, and now Kim and I do them ourselves. So what you're trying to do is look for outliers or to make sure that your results are consistent, you're not having more complications. So I think a lot of people, I talk to a lot of colleagues that we do this, and a lot of them are actually very envious that we've got this ability to do that, because the majority of plastic surgeons don't audit their work because most people are solo practitioners, so it's hard to get someone else in to do it. And those people in groups, maybe, what would be a good word? Lazy? Can you say lazy? Got to set aside time. We've got to prepare for it. Yeah, you've got to come in the weekend before and put all the cases together and go through your numbers. But it's a really, really good way of making sure that patients are getting the best possible care, and that we're both doing the best that we possibly can for every single operation.
What prompted the start of the audit?
I think it's just good practice. We've been doing this for a long time. One, it's a good thing to have in the diary so that we're actually catching up with each other, because we're often not in the rooms at the same time. So it's a time to sit down and just chat about difficulties and things like that as well. And also I find that whilst you're looking at the other person's work, you're actually critically analysing your own work as well. And it's interesting when you look at post-op photos that we are discussing, and the cases that we're discussing have had their last appointment with us, which is 3 to 4 months post-surgery. And a photo, there's nowhere to hide really. Like when patients, you've got them in front of you, often the patient's happy, says thank you, and that they're pleased we take their images. And I have a look at the photos and I'm like, oh yeah, there's always little things that you pick up more in the clinical photographs because they're so in your face. Whereas a live human is moving and things are 3D, so it's like any little asymmetries are less obvious.
The key to any good self-audit is setting clear goals. Have you set certain ones, or do they kind of change every time you do it?
There are a number of metrics that we look at. So firstly, we look at sort of the number of cases that we do. So we break it down by operation and compare it to the previous quarter to see if there's any trends. We like to compare sort of how many cases that we're doing compared to each other. So that's just a basic number audit. So nothing clinical in that. Then we look at the short run complications. So return to theatre, readmission to hospital, bleeds, wound infections, wound problems. So things that might happen in the first couple of weeks. And then we have a section of the audit where we nominate a procedure, say tummy tuck. We do all the audits, just to put this into perspective. I think we're about sort of 6 months or so in arrears. So we've got a 3-month result. We do consecutive cases and we pick an operation, whether it's a tummy tuck or a breast reduction. So if this quarter it's a breast reduction, I'll present 5 breast reductions in a row. Kim will present 5 breast reductions in a row. So then we're looking at the long run outcomes and analysing our actual results, looking at the aesthetics, looking at symmetry, looking at overall cosmetics to make sure that, there's nothing that we're missing. And, we're honest and critical of each other's work, but
and of our own,
of our own work particularly. But yeah, there's really those three components.
What have you learned from auditing your own work?
I think one of the first really interesting things that I picked up when I was going back through the patients was that not everyone was coming to their 4-month follow-up. And so I think one of the first few audits, it was around 70% to 80% of patients weren't coming to that final appointment. So we'd seen them usually at 1 week, 2 weeks, 6 weeks, and then they either rang and cancelled or didn't show up. I guess our assumption is if someone doesn't come for that appointment, everything's fine, but we don't know that. And so you can't actually include that as a good result in your outcomes. And so, which I think is important, even if the patient's happy and their result's good, like, yeah, it'll be a short appointment, but we'd rather see someone and just talk through any issues or anything that they had.
No, I think it's made me look at aspects of what I'm doing. So a couple of things that I've changed since we've started doing them. So one thing that we look at is revisions, so scar revisions, and by far the most common thing are dog ear revisions. And in the tummy tuck, just that side fullness. So I've tried to address that in sort of how I mark the patients up, and also trying to address that fullness on the table, because I can't remember what the numbers were, but we were maybe doing sort of maybe 5 to 10% revisions. So I think I've got that down for tummy tucks. The other area was the Mons area. So I know it's a big sort of bugbear of a lot of patients. And I was doing some revisions of the Mons area, mainly a bit of liposuction. So I've introduced that into the actual operation to try and reduce the risk of that. And probably the last thing that I've changed is seromas. So build up of fluid. I initially started leaving drain tubes in longer, but I've now gone back to sort of suturing that skin down onto the tummy wall to close off the space to reduce that. And I've been doing that now for 6 months and haven't had another abdominal seroma. So seroma is not a big deal, but again, it was about sort of 10%. It was just sort of annoying level for me and for patients. So it's been a very useful thing. I mean, these aren't major revolutionary changes that change the long-term outcome, but just trying to just constantly improve. So, there's no point doing this if you're not going to learn from it and get better.
Obviously, you guys audit each other's work. Do you ever disagree with each other's assessment?
I wouldn't say we disagree, but we also do use it as a platform to ask questions. Like if there is a patient, there's a sort of a supplementary, it's like Tats Lotto, there's a supplementary number where if in that period there's been a patient who it's been a bit difficult and the result isn't exactly where you want it, that's an opportunity for us where we don't sort of have to make the time, because we've already made the time, to share that patient and get a second opinion essentially for the patient, or to test what your plan is to go forward, or even with new patients that are a little bit more difficult or a little bit more complicated, or whether they're a good candidate for surgery. And we'll both bring cases and say, look, I saw this patient, let's just say they've got a scar on their abdomen, they want an abdominoplasty. Do you think this is going to add risk? Or the common one with breast is they've had a previous breast reduction, they're going to have another one. Is the nipple blood supply going to be reliable? And it's just a great opportunity, which a lot of other surgeons and patients don't get the benefit of getting really two opinions from two experienced plastic surgeons.
Are there any requirements on surgeons to do audits?
So every year we need to complete what's called the CPD, which is continuous professional development. When you're solely in private, which is what Kim and I are, so we have worked a lot in public, but we don't anymore. So one of the reasons that apart from we like doing it, but it is actually a requirement. And I think one of the problems when people have a mixed practice, whether in public and private, is they can use the public hospital audit sort of to tick that box on their CPD. And the public hospital audit is really meaningless for an individual's practice, because they're looking at high risk cases. They're really just looking at, major complications and major complicated trauma patients and things like that. And so they tick the box, and I think one of the reasons they maybe aren't so focused on it in their private practice is they've ticked the box and they don't have to do it. So because we're in private practice, we still need to do the same requirements. And so it has motivated us to develop this system. It's a very different, when you're in the public hospital, patients they come and they go, and there's sort of not really any long-term follow-up. And when you're doing plastic surgery, the complications, the short-term complications we usually see are pretty minor. They don't have a long-term impact. Obviously, you don't want to be getting, a hematoma every second case, or someone having to go back to theatre every second case. That would be a massive outlier. But if there's 1 or 2 cases a year, it's not really a big deal. But the long-run outcomes is a big deal. Plastic surgeons who are working in public hospitals, if they are doing any cosmetic surgery, they're unlikely to be putting themselves through something like this, which we're very devoted to and committed to make sure that we're getting the best possible results.
If you liked that episode, there's plenty more where that came from. Maybe start with some of these, or head to our channel for your peek into the mysterious world of plastic surgery.